The standard clinical treatment for metabolic syndrome relies on polypharmacy. Patients receive distinct prescriptions to lower blood pressure, correct hyperglycemia, and manage elevated triglycerides. This strategy fails to halt disease progression because it addresses phenotypic symptoms in isolation, leaving the underlying biological dysfunction active. The driver of these conditions is the gut microbiota, functioning as a virtual endocrine organ by producing signals that regulate systemic energy and inflammation. When microbial diversity collapses, opportunistic pathogens release toxins into the bloodstream, triggering the chronic low-grade inflammatory response known as metabolic endotoxemia. Biotic interventions aim to re-establish systemic metabolic homeostasis at its source by rectifying the microbial dysregulation driving the syndrome. Dysbiosis begins with a specific microbial shift, a decline in the bacteria that produce short-chain fatty acids, and a rise in opportunistic gram-negative pathogens. These gram-negative bacteria possess toxic outer membranes containing lipopolysaccharides, or LPS. Their overgrowth degrades the intestinal lining, allowing LPS to translocate into the systemic circulation. This diagram shows gut-derived inflammation spreading into multi-organ failure. In the liver, endotoxins accelerate lipogenesis and fibrosis. In adipose tissue in the pancreas, LPS drives obesity and insulin resistance. Finally, altered gut-brain axis communication reduces central satiety, making food regulation physically difficult. Effectively managing this syndrome requires treating this interconnected signaling network rather than applying isolated interventions to terminal organs. Clinical interventions use three classes of biotics: prebiotics, probiotics, and postbiotics. Prebiotics are fermentable substrates, like fiber. Probiotics are live microbial strains that consume them. Postbiotics are inanimate bioactive metabolites and cell wall components that do not require live colonization. Categorizing these by their physical state is critical for predicting their survival in the gastrointestinal tract and their eventual pharmacokinetic behavior. Within the colonic lumen, live probiotics actively ferment prebiotic substrates. This fermentation produces short-chain fatty acids, or SCFAs, specifically butyrate, acetate, and propionate. These SCFAs function as signaling molecules by docking with G-protein-coupled receptors, GPR41 and GPR43, located on colonic enteroendocrine L cells. This receptor activation prompts the L cell to secrete the hormones GLP-1 and PYY into the host bloodstream. GLP-1 potentiates glucose-dependent insulin secretion from the pancreas, lowering blood sugar. Simultaneously, PYY signals the hypothalamus to increase satiety and reduce voluntary caloric intake. Restoring SCFA production directly reverses hyperglycemia and hyperphagia by re-establishing the gut endocrine axis. The gut also communicates directly with the liver through the portal vein. Specific probiotic strains possess bile salt hydrolase activity, an enzyme that cleaves primary bile acids into secondary bile acids. These secondary bile acids function as specialized signaling molecules within the intestinal tract. Secondary bile acids activate the farnesoid X receptor, or FXR. This triggers a negative feedback signal that travels to the liver to suppress hepatic lipogenesis. The bile acids concurrently bind to TGR5 receptors, which increases energy expenditure and promotes further GLP-1 release. Microbial modulation of the bile acid pool shifts liver metabolism away from fat accumulation, directly intercepting the pathogenesis of hepatic steatosis. Live probiotics face high mortality rates against gastric acid, bile, and competitive resistance from native flora. Postbiotics bypass these survival bottlenecks by providing therapeutic effects without requiring live colonization. Their therapeutic payload consists of structural cellular components, such as peptidoglycans and surface layer proteins. These structural components act as microbe-associated molecular patterns that bind directly to toll-like receptor 4 on host macrophages. This interaction dampens NF-kappa B signaling cascades, turning off the cell's pro-inflammatory output. This shifts the host immune profile to a regulatory track state, characterized by the secretion of the anti-inflammatory cytokine IL-10. Simultaneously, surface layer proteins upregulate the expression of tight junction proteins like claudin-1 to physically seal the intestinal barrier. Sealing this barrier stops the translocation of LPS into the portal vein, halting metabolic endotoxemia at the source. Postbiotics offer a stable method to enforce barrier integrity and quell systemic inflammation without the liabilities of live cell administration. Biotics achieve multidimensional modulation across the gut-brain, gut-liver, and gut-immune axes. This integrated receptor-level approach addresses the disease mechanics rather than just managing phenotypic symptoms. However, clinical trials often observe a washout effect, where metabolic benefits disappear once supplementation stops. Clinical data also shows a stark divide between responders and non-responders. A patient's baseline microbial profile dictates their functional capacity to ferment specific prebiotic substrates. Because of this individual variability, a one-size-fits-all approach to biotic dosing is biologically insufficient. The future of treatment lies in precision microbiome medicine, where interventions are matched to the host's specific enterotype. This involves the design of synergistic symbiotics, where specific prebiotics are rationally matched with biologically compatible probiotic strains to guarantee SCFA output. While metabolic syndrome is driven by microbial dysregulation, the solution relies on engineering targeted, stable interventions that permanently restore metabolic homeostasis.